Hello, OT friends, and welcome to the Uncommon OT series. My name is Patricia Modis. I'm the Transitions OT, and I'm your host. So today, I'm super excited to introduce you to our guest of honor, Vanessa Monique Yanez. So Vanessa is an occupational therapist with a specialization in oncology. She is a cancer survivor and an advocate for rehabilitative services across the continuum of cancer care, from prevention to survivorship. She holds a faculty position at the University of St. Augustine and runs a private practice in San Antonio, Texas. Vanessa is a frequent presenter at state and national conferences and is currently pursuing a Ph.D. from Texas Women's University. She strongly believes that occupational therapy coalesces compassion, research, and a client-centered approach in a unique way that can help cancer survivors not only function, but fully participate in a life that they deserve. Her clinical and research interests include hematological cancers, stem cell transplants, psychosocial supportive care, sexual functioning, and theory-driven practice in cancer care. So without further ado, I'd like to present to you Vanessa Monique Yanez. Hi, Vanessa. Welcome.
Hi, Patricia. Thank you so much for having me.
You're welcome. It is my pleasure to have you on the show and to have you just talk about your expertise in cancer care.
Thank you. This is a topic that I can talk about nonstop. So stop me if needed.
Well, that's exactly what we're looking for is someone who feels really passionate about the work that they do, right? Because that's typically a theme that we have here from our guests is that everybody is really just so passionate or really feeling driven by the work that they do. And that, kind of brings you here. So thanks for spending the time with us. Excited to delve into all of your expertise, but as usual, before we get there, I'd love for you to tell us just a little bit about you, a little bit about your background, please.
Sure. So I was born and raised in Southern California. I moved to San Antonio, Texas a couple of years ago. I specialize in oncology. This is what I've been doing pretty much my entire career. I ended up in an oncology setting during a level 2 rotation. And then sometime after graduation, I was offered a full-time position. So that's really all I do and that I know and that I love to talk about. But I came across occupational therapy after my own personal experience with cancer. I was 19 when I was diagnosed with cancer. And at the time, I had just finished or about to finish my first year out of college. So I was really just enjoying that independent life, that young adult life, this newfound freedom. And I was dating and I was going out having fun when I get this diagnosis. And it just turned my entire life around. I became dependent on others. I pretty much lived in a hospital for many months, and it became really my home. So after that experience, I learned that the hardest part of cancer wasn't necessarily dealing with cancer and the side effects and treatment, but trying to live a life after I recovered or as I was recovering. And I received OT services throughout, inpatient, outpatient side. And I really was able to connect with occupational therapy and what it did for people, because it just, for me, I feel like it saved my life. It gave me purpose and a vision for the future. So after that experience, I said, I really want to go back to school and go to OT school and then practice. So that's really what I've been doing since graduation. And recently as well, the past couple of years, I really love to talk to people about what OT does. And so I went into teaching. And earlier this year, my husband and I, we went into private practice. He's also an OT.
Ah,
He's in pediatrics.
okay.
Yeah, so it was a really nice blend where we can serve both the pediatric and the adult population. But I just see patients with cancer. And I've always been really interested in research too. So really trying to combine clinical practice and research. So that's where the PhD happened. So I'm really excited of a lot of the work that I'm doing, and hopefully get to show that to other people. But whenever I'm not working, which is not a lot of time, I really love to dance.
Oh.
I'm a big salsa dancer for sure. My mom says that ever since I started walking, I've been dancing.
So you're salsaing instead of walking.
There you go. Yes, all the time. I love to shop for plants. And I say shop because I'm not really good at keeping them healthy and alive. my, my husband does that. He does a great job. But for me, I love to plant for shops. And the other thing that I like to do, and this is a really fun thing for me, is creating PowerPoints. I'm not sure who else likes to do this, but I feel like it just combines my love for teaching and talking with like creativity and like putting something out there. So I have a lot of fun creating posters and presentations.
Oh, I may reach out to you for some of that because that's definitely not my strong suit.
Anytime.
But thanks so much for sharing a little bit about yourself, your favorite occupations, all the way to sharing a little bit about your survivorship and your cancer story, your personal story, and how that really motivated you to go into this type of work. I love what you said about how the hardest part of living with cancer is not necessarily just the getting the diagnoses and necessarily going through treatment, but it's still continuing to live your life as full as possible, right? And this is where OTs come into play.
Definitely. I really feel that OT is, I want to say like the perfect discipline for a lot of cancer survivors. And I think part of the reason why a lot of people struggle afterwards is because as someone is going through treatment, there's typically a lot of support. So you have your physicians, you have your nurses, you have rehabilitative services, you have psychosocial services. But once someone is done with treatment, sometimes they're just left to almost like fend for themselves like afterwards, and they're like, you're done with treatment, you are a cancer survivor, you have completed everything, you can go on and live your life. But then you're different, you're not left the same after being diagnosed with cancer, and you don't know what to do. Like, how do you continue on living when you're sometimes left with impairments and the trauma of that cancer experience?
Yes.
So I feel like OT is just that blend of that discipline that just combines everything, that holistic perspective to really see and help cancer survivors.
Fantastic. So I want to dig a little bit deeper into that, and maybe you can tell us more about the uncommon OT work that you do currently with cancer survivors, and then we'll segue into maybe talking about the types of goals that you might have, the types of treatment sessions, and give us sort of a little glimpse on that.
Sure. It's so interesting whenever you say uncommon, because I'm like, this is all I know. So this is pretty common to me. But it's true. A lot of OTs, and I've heard this from a lot of people, they don't really know that OT is in the setting. So it's always interesting to hear that from other OT practitioners and OT students.
Yes, and from my very little knowledge of OT in oncology, my immediate impression is that, okay, we can find them mostly in acute care settings or perhaps a rehab setting. But, we're talking a little bit more about beyond that, right? We're talking a little bit more about helping people really live beyond the hospital. So I think, your work is even more uncommon in that case.
Mm. Well, it really is interesting. I've been in many settings within oncology. The field or the area of oncology is similar to PEDS, where it's this umbrella term, and then under PEDS you have your school-based therapist, and you
Mm-hmm.
have your physicists, pediatric therapist, home health, early intervention. So similarly in oncology, we have all of these subpopulations. So we have our breast population, we have our hematological population, our surgical population, transplant population. So it's a very much diverse
Mm-hmm.
area within oncology. But I've been very fortunate and blessed to have worked in many settings. So acute care, inpatient rehab, outpatient, home health, telehealth, and I've really enjoyed every single one of them. I feel that there's definitely a need from patients and they value OT so much too.
Mm-hmm.
So I've really enjoyed working with this population within various settings, but it really depends the setting and the population that really makes a difference on my interventions.
Mm-hmm.
So if I'm in acute care, definitely there's more attention placed on ADLs,
Mm-hmm.
self-care, getting dressed, taking a shower, going to the restroom, safety with transfers. And typically that's also done right after a surgical procedure,
Mm-hmm.
or if someone's going through intense chemotherapy or radiation inpatient where they're very debilitated and there's a lot of
Mm-hmm.
weakness. So that's pretty common. And that's something that we share with other OTs and in different settings and populations.
Mm-hmm.
Um, on the outpatient, I have so much fun outpatient because by then they're stable. Typically, they're able to get around, ambulate. So by then, I would say I mostly do like high level activities or occupations. And by the time they come to me outpatient, like they want to go back to work, they want to go back to school. So I do
Mm-hmm.
a lot of return to work and school activities. Let's see, what else do I do? There's some things that I do across all the settings.
Mm-hmm.
Um, Aside from ADLs, IADLs, of course, that's also across all settings too.
Mm-hmm.
I would say with some of the most common interventions would be managing their home. So a lot of the side effects really affect someone's ability to manage their home, take
Yes.
care of their children, drive them to work. Um, Medication management is another big one.
Mm-hmm.
A lot of the medication that they need to take literally is saving their lives. And it could be sometimes oral chemotherapy,
Mm-hmm.
the immunosuppressants after a bone marrow transplant. So this is medication that they must take, or it might lead to a relapse of cancer.
I see.
So it's really important for them to be taking the medication. And it's not just a couple of medications at times. There are some situations or patients like those that have gone through transplants are taking 10, 15, 20 medications, and
Yes.
they've never taken medications like their whole life. And so that is really a new, tricky, challenging situation for a lot of them.
Mm-hmm.
So for me, that is a pretty common intervention to work on.
It's almost like a new role that they have to get to know and learn and sort of develop strategies for.
Definitely, definitely. It's this role of a survivor that now has to pay a lot more attention to their health in terms of
Yes.
medication, managing appointments. A lot of them
Mm-hmm.
too, like they went from seeing their doctor twice a year to maybe seeing them twice a week. And
Mm-hmm.
that's just their physician, not accounting for labs and tests and
Mm-hmm.
other specialized providers. And so some survivors just have difficulty remembering and managing all of these appointments too.
Yes, we've talked in the past about side effects and, that really being one of the most debilitating effects. And these are the side effects of the cancer treatment that folks get. And, one of them being chemo brain. It's referred to out there in the text. Can you talk a little bit more about that and perhaps any goals or interventions that you may have worked on with some folk?
Yeah, definitely. So with chemotherapy, one of the side effects of chemotherapy, and there's multiple ones. We have physical side effects, we have psychosocial side effects, and cognitive side effects. And so one of the things that happens at times is someone who receives cancer therapy, chemotherapy, might experience chemobrain or cognitive dysfunction. And this could be maybe just forgetting where you place things. You might be forgetting a lot of words that are pretty like simple words too, that most people don't have trouble forgetting.
Mm-hmm.
It might be difficulty processing information. Your brain might just take more time. So there could be a lot of cognitive changes as a result of chemotherapy or other cancer treatments.
Mm-hmm.
And these, it ranges on the severity. So you might see it very minor. And there are a lot of cancer survivors, even like myself, who 10, 15 years after their cancer treatment still experience chemobrain. So I still do.
Mm-hmm.
But because I'm an OT, I know how to manage it very well. But you have a lot of cancer survivors that are working or are in school, and they're still having issues because their brain is not working the same way that it did prior to the cancer diagnosis, prior to cancer treatment.
Mm-hmm.
And along this continuum of severity, then you have those that it becomes more obvious too,
Yeah.
where you're talking to someone and you just know as an OT, like something's not quite right. And then you have keeping going down this continuum, those that it's really impaired or it's impacting really safety too, where they forget to turn off the stove, they forget to lock the front door, even though they're still able to talk to you and move around. But as an OT, we can see those cognitive deficits.
Yes. And, I'm sure that also impacts their relationships, their ability to participate in their roles, such as parenting, be a worker, etc. So
Yes,
I totally see where the OT lens comes in and how we are the perfect discipline to work with this population. So thank you
definitely.
so much for sharing with us some specific examples of the types of issues that you might see, the types of goals that you might work on with clients in these very different and distinct settings. It's like you get a patient at a different functioning level at each of these places. So I love that your current private practice focus is in the outpatient services, right? Because like again, that kind of you talked about that giving you more opportunity to really work on higher level goals with some of our clients. Can you talk to us a little bit about, just how a typical session might be like? Maybe the assessment process. Are there any types of assessment tools that you use? Which ones are your favorite? And then kind of how do you get to goals once you've done your evaluation?
Yeah, so that really depends on the reason for the referral, but I do have my general OT evaluation. I would say that because of the population that I work with, and I tend to see more of those high level individuals, people that are able to some degree, take care of their children, take care of their households, go to work, drive around, but they're just not satisfied with their level of performance. There's
Mm-hmm.
still some impairment and they're experiencing it, even though it might be not so obvious to other people. So a
Yes.
lot of the assessments that I use are more subjective. So I'll use the COPM, just like a general one,
Mm-hmm.
and then I'll definitely incorporate other ones. So if someone is experiencing chemobrain, for example, I might use the fat cog. So I use the fat cog for cognitive changes. If you go to the website Facet, that's where you can find the fat cog. And then there's other ones that are very depending on the symptom or diagnosis. So there might be another one for fatigue. That's the Facet F. There might be some for transplant patient as well. So it really depends on the referral and the reason for the need of OT services.
Got it.
But I do a lot of screeners as well in between that first session. So I'll do a general, like comprehensive, like holistic OT assessment. I'll combine that with something more specialized. And then I do a lot of my screener. So I look for, any concerns with body image, with
Mm-hmm.
how they're coping with sexual functioning, with their relationship with their partners, their caregivers. So I'll do a lot of quick screeners. And then depending on what I get, then I might do a more in-depth assessment on that.
Got it. It sounds like there's a big psychosocial component in your assessment process and also your screens.
Definitely, yes, because cancer affects the body, the mind, the spirit. Every aspect of a person can be really impacted by cancer. So we can't really separate the mind from the body. So, and as OTs, we have that really that holistic lens to see the whole picture.
Yes, it's automatic for us to
It
see
is.
from those eyes. So, again, perfect discipline to work with this population.
That's what I've been saying.
So, thanks for sharing with us some of those assessments, and we will list them properly in our notes. Tell us, I know you shared earlier that you kind of found this path through your level two field work and through your own journey of cancer. Is there anything else that you can share with our listeners as far as can they do to kind of follow this path?
That's the way I got started because I didn't really know how I was going to end up in OT when I went to OT school. I guess I just hope for the best, and that's not the best advice that I will give. That's just the way I ended there because I had my own experience with cancer. I knew that OTs had worked in oncology, but then I came to find out that there aren't a lot of placements in oncology necessarily. So when I was in OT school, and this was during my second year, there was a class, and I believe it was conditions. We had two guest speakers from the same hospital where I had been, City of
Mm-hmm.
Hope. In
Oh,
Southern California.
yeah.
And one of them was the manager of the OT department, and the other person was an OT who later became my fieldwork educator. But I have to provide some context because they came over to talk about cancer and occupational therapy. And I used to be really shy and not really a talker at that time. And when they came, I told myself, like, you have to get up and you have to go talk to them. I wasn't that student that would, go up and approach the instructor or speaker separately because I was just really embarrassed. But so after their presentation, I was just really excited they were there and talking about cancer. And they had already left the classroom. And I just thought to myself, Vanessa, this is now or never. Like, you go talk to them and you ask for if there's a possibility of a level two placement. And I literally ran down the street and towards, towards where they were parked. They were really close to getting to their car. And it just like waved my arms, like, stop, like, hey, thank you so much for coming. My name is Vanessa. So I introduced myself and I told them a little bit about my own experience. And of course, at the end, I just asked, I'm like, hey, by any chance, do you have a level two placement? And they said, yeah, we do. Talk to you if you're a coordinator.
Oh, I love that.
Yeah, so that's it. Initially, though, it didn't work out. So I talked to the fieldwork coordinator, and she said, "You know what? It just, in terms of timing, it's not going to work out. They don't have a placement during the time that you need a placement." So I kind of just begged, and I'm like, "Please, like, you don't understand. Like, this is why I came into OT. Please,
Mm-hmm.
please try again." And she did, and then I got a level two placement there. Um,
Oh,
it was
fantastic.
really just, I feel like it was meant to be for sure. And it was such a great experience. So I would advise students to try and advocate for themselves if needed, to try to get a level two placement in oncology if this is an area they're really interested in.
Mm-hmm.
Typically, it's a very diverse population, high pace, high complexity as well, but it's a very exciting placement. I learned so much. And I'm just so grateful for that experience, really. So I feel like that's one way.
Mm-hmm.
So the other way would be if someone is doing their OTD and they're working on a capstone or their master's thesis, look into oncology too. Like, that's a really great way to connect with any cancer hospitals or oncology units or oncology therapists in your area. And
That's
so
great
from that
advice.
relationship, you just never know what's going to happen.
Yes.
So that's another way. And then I would also say, if you're interested, try to look for any classes or conferences that have courses in oncology. So AOTA has those, ACRM has those. Look within your state conference, like TOTA, for us here
Mm-hmm.
in Texas, OTAC in California. They typically have an oncology course. And so approach those therapists that are teaching or anyone in that room and see who you can connect with.
Got it. Thank you for that advice. Can you talk a little bit about some recent highs or recent lows and successes or challenges that you may have had in your role? Any of your roles?
I think the best one that I can think of right now, and this has just warmed my heart, was a patient who came back. She's in her 20s and came back and talked about how her treatment was just the darkest point in her life. And the only time really that she felt like some sense of happiness and joy was when OT went in. And because of that, she wanted to go to OT school. So I'm like, yes, yes,
Oh,
yes, yes.
wow.
um,
That
that
touched
was
my
really
heart
fun.
too.
Yeah,
And
that
I'm
was
sure, from your own personal experience having being diagnosed at such a young age and, working with this young lady who's also, at a very sort of early point in her life, how much that really meant to you. This is what you're doing this work for.
exactly, exactly. So it meant a lot to hear it from someone that's going through it, that it just had that much of a profound impact. And I know that because I felt that too.
Yes. Oh, thanks so much for sharing that high with us. I should really ask this question in reverse so that we end with a positive, because now I'm gonna ask, are there any recent lows? And if there aren't any, that's okay too.
With the lows, because of the setting, inevitably is someone passing away.
Mm,
And with a lot of our patients as OTs, we make that connection and have this beautiful relationship with a lot of our patients.
yes.
So at times, even though we're in a professional setting, we still connect at a level where we care for them and we know their families' names and we know what they love to do. Like we get to know them at a personal level
Yes.
too. So I feel like that's always a hard one to go through. It's losing those patients.
How do you manage that from a professional, not burning out place and in a place where, yeah, you're able to kind of make sure that your boundaries are
Hmm.
are firm, right? So that you're also keeping yourself safe from all this. I look at this as trauma. It's vicarious trauma.
Hmm. Yeah, yeah, it really is. I feel that for me, one of the things that has helped is taking or having a perspective, or I wouldn't say perspective, but understanding death as just a normal process that we're all
Hmm.
going to go through. And it's inevitable in every single person's life where there's going to be an end, but it's not so much how much they lived, but how well they lived. And for me to be able to be in someone's life towards the end of their life and to have that privilege, that helps me get through it, where I felt like I was able to make a difference in someone's life towards the end of their life. And that was a special gift that I have with me, and that I can take on. And so I feel like when one of them passes away, I do take a moment to mourn for sure,
Hmm.
and just be grateful for the life and for giving me the opportunity to be in their life too.
Thank you for sharing that, Vanessa, and your way of kind of terminating, right? Terminating your relationship with your patient that you've kind of developed such a close tie with. So thanks for that. It reminded me a little bit of when I worked in an HIV program, and this was back in the 90s, and more folks were dying of HIV then. And I really do remember a time working in this outpatient program, and I would say on a monthly basis we would lose one or two of our participants, and how difficult that was to process, not just as a clinician, but also as part of the community, because that's what we had, So again, thanks for sharing that. I think that, therapists and future therapists alike can benefit from that type of personal advice.
Yeah, yeah. And I think I remember that we're humans. We're humans, and we feel and we're connected with other people. So it's okay to be sad and to mourn the loss of our patients. So I feel like it's definitely okay to be in that space. Yeah. And I feel sometimes sad, but more so I feel grateful, just really grateful that I had that chance to be in their lives.
Yes. So thank you for sharing that again. Can you share with us a little bit about how do you stay on top of the work that you're doing on cancer research? I'm sure that impacts interventions, assessments, etc.
Oncology in OT is still considered an emerging area in our field. So I know that's going to take more time. So hopefully it becomes standard practice setting. But I definitely rely on any new articles that come up. And there's some researchers that I follow that I'm a big fan of. So I look them up because they don't necessarily publish just in AJOT. They're published in other journals as well outside of OT. So I follow their work. And sometimes I'll also pull from other disciplines too. So if it's something related to mental health in cancer care, I will look at social work journals or psychology journals, and then pull something that's something that we use in OT.
Yes. And you're also very research driven. Do you have any research that you'd like to talk about today?
Yeah, let's see. So one of my favorite researchers in oncology, her name is Alex Slight. I love a lot of her work, and I'm always reading and rereading her articles. But there's one in particular that I really like, and I believe it's something along the names of like OT being in expanding our role into psychosocial supportive care. And she talks about the needs of the oncology population, because there really is a need, but a lot of patients are not getting referrals. And that's where we need to really continue our work in advocating what we do, even within an oncology setting, because a lot of people don't really know what we do. But she talks about...
Can you tell us how we can advocate for ourselves within these settings?
So what I do is I try to see where is the need within that setting too. So for example, a lot of doctors, what they want is their patients to show up for appointments, to be taking their medication, to be moving. So as an OT, I'll just say, hey, these are things that we can be working on with your patients. Like pretty much, let me help you. Like you don't have to do it yourself. Refer them to me, and I can work on this with my patients, with our patients, and I can relay you any updates. So I feel like as a community, within this community, I just try to find that need to get that referral. And then once I get that referral, I can do a lot of other things that we do with occupational therapy.
Got it. So most of your referrals are from the physicians or oncologists that you've networked with.
Yes. It's important to have that communication with doctors, with NPs as well, with nurses, just within that multidisciplinary cancer team.
Yeah. And I love that you're taking a very functional approach to explaining what we do, right? And really kind of going with, okay, these are the problems that are very typical with this population. I can help with that.
Yes, because people want the help of others.
Yes.
Right? And it just also shows that we're all on the same page together. We're all tackling the same things. And within the article from Alex Light that I was talking about, she actually mentioned that some of the major unmet needs with cancer survivors is related to functioning, daily functioning. That's our bread and butter. Related
Mm,
to mental health, another area that we know of, and related
yes.
to quality of life issues, major within occupational therapy. So I
Yes.
feel like all of these things definitely tie OT into the setting.
Wow. So this is so great. Um, Going back to your private practice that you've started, can you share with us a little bit more about that? Perhaps a little bit about how you charge for your services, how you're able to. We talked a little bit about getting referrals, but yeah, anything else that you can share with us?
Yeah, so it's a really exciting time to be working with this population, to be working with my husband too. So he does a lot more of the pediatric population. He specializes in autism. And a lot of what I do is seeing adults with cancer. So right now, for the most part, actually, we've been private pay, but recently we got credentialed through some insurances. So we are taking insurance now. Um,
Congratulations. I know that can be challenging to get credentialed,
it was a lot of work for sure.
but then that opens up options for the patients that you serve.
And that was one of the reasons why we decided to go through credentialing. I think private pay is definitely easier
Hmm.
and less stressful, less headaches, where we don't have to deal with insurance companies. But the reason that we wanted to go through insurance is because with my population, a lot of them are on Medicare, like they're older adults on a limited fixed income,
Hmm.
and would not be able to afford OT or rehab services on a weekly basis. So
Got it.
I really wanted to make it more accessible for that population. So that was the primary driving factor for going that route as well.
So typically, how often do you meet with your patients and for how long?
It's more on a weekly basis, depending on the need. In terms of timeline, I would say somewhere along 2 to 3, no more than 4 months
Okay.
on average. Yeah.
Are there any misconceptions or myths that you would like to demystify today when it comes to your current role working with this population?
I would say the biggest misconception about working in oncology is that it's a sad and depressive setting. I think there's the myth that a lot of our patients die and that there's going to be significant decline in their health. And although that happens from time to time, generally it's not a sad and depressive setting. In fact, it's a really exciting, fast-paced, and dynamic setting because every single day is different. Every single patient is different.
Mm-hmm.
So I've really enjoyed working in the setting. So I highly recommend it, even though I'm biased, of course. But I think it's one of the settings that if you really like change of pace and complex patients and being in this dynamic and fast-paced environment, I would highly recommend checking out the setting. Yeah.
Thanks, Vanessa, for sharing that with us. And I agree. You're in a place where you're helping folks improve the quality of the lives that they're currently living, right? There's a lot of gratification in that at the end of the day.
There is, and they also really appreciate it too. Because I've
Mm-hmm.
been in other areas or fieldwork rotations where you put in so much heart and you should definitely keep at it too, but you don't really feel like there's a sense of appreciation for what you do. And I feel like OT is definitely one of those underappreciated disciplines in general. But in this setting, I think because the need is just so obvious and so much needed, our services are really appreciated by our patients. So I feel that being able to address a lot of those quality of life issues with our patients. And that's actually another misconception too, is that a lot of what we do in oncology is very much phys dis.
Mm-hmm.
And
That's
it
what I
is,
thought.
yeah, I mean, maybe a little bit. I would say, for example, for me, it's maybe like somewhere along 30% on average of what I do. I would say definitely more psychosocial interventions for me. I also do a lot of lifestyle interventions. That's a big one too.
Yes.
So addressing sleep, addressing stress, I'll do routine building, exercise, all of that's another major component of my work too in oncology.
I'm glad that you pointed that out because as OTs, I think this is really, this is why our lens is so important with this population, is because we have the ability to really recognize how each of those systems are affecting the other, right? And not just really being so focused on just the physical rehab portion of things, especially with this type of diagnosis. Thank you so much for sharing with us again your story and just giving us just a different glimpse, again, because of your own journey and the type of thoughtfulness and sensitivity that you're putting into your work. That's another piece that makes you extra effective in your work, is that you can really relate to what these individuals have gone through.
That's true. It definitely is very meaningful and purposeful for me. And I feel that it's not a job, it's definitely a calling and a purpose for me. And I also feel that it's something that a lot of us can relate to. I feel that most of us know someone or have been diagnosed with cancer. So I feel that even if it's not yourself, like, you know, someone close to your friend or family member who has been diagnosed with cancer. So you still have that connection with people within this population in that way too. And because family members are also affected, it's not just a survivor, but children, parents, family, friends. They're also afraid. They don't know they're going to have you for a long time. They don't know what you're going to go through. So cancer is one of those diseases that just affects the person and the community around them.
Yes, I totally see that. So again, thank you so much for sharing your expertise, your experiences. If we want to follow you, ask questions, be in touch, how do we do that?
Yeah, there's a number of ways, and please reach out. I love to talk to people about oncology, especially if this is something that they're interested in or trying to expand a practice. But you can reach me at my email. So that's vanessayanez1@gmail.com. You can also find me on social media. And recently I started an account on Instagram. It's called the OT. That's TheOncoot. And I post a lot on what we do as OTs. And that's another creative outlet for me as well.
Yes.
Posting there.
I love your posts.
Oh, thank you. So people can definitely reach me that way. I'm also at conferences typically, so I'll be at AOTA. I have a workshop and 2 presentations during next year's AOTA conference.
Fabulous.
Yes, so please come and say hi. The workshop is going to be on just generally what OTs do in oncology, and that's a 3-hour workshop. And then the presentations are going to be on, one is psychosocial care in oncology, and then the other one is sexuality in oncology. And then I'm also going to be at WFOT, so hopefully Paris happens.
Congratulations on all of this, Vanessa. That's fantastic.
Thank you. So please stop by, look me up, and come say hi.
Oh, I'm sure folks will. Now I'm thinking of going because you'll be there.
Definitely, yes. We'll grab some coffee.
Well, thanks again for your time. Thanks for sharing all of this information about you. This is such valuable information for OTPs and future OTs who have a special interest in oncology.
Thank you for having me. It's been a pleasure.
And that wraps up another inspiring episode of the Uncommon OT series. Connect with me at www.transitionsot.com. And don't forget to sign up to be part of the Transitions OT community. By doing so, you'll receive my latest compiled list of uncommon OT practice settings, the latest news on mentoring offerings, uncommon OT live events, non-traditional OT resources, and more. You may also follow me on my social media pages on Instagram and LinkedIn. And if you love this episode, head on over to Spotify, Stitcher, Apple, and Google Podcasts to follow, rate, and leave a review. I also ask you to consider pledging your support to my Passion Podcast project by by being a patron on Patreon. It is very much appreciated. Sending big OT love. Thank you so much for listening. Until next time.